I'm Matthew Traynor, Chief Executive of the Trust, and we're going to just run through a bit of a presentation as part of the well-led. And I wanted to say welcome to you. I know some of you have been here already for a couple of days, so you've had a good chance to have a look around the place. But I'm going to talk to you a bit about the Trust's journey in recent years and what we're trying to do at the minute, and hopefully to give you a bit of a frame for the interviews you'll have over the next couple of days. And we've also invited leaders from across our divisions to join us here as well. And we are going to record this as well and just stick it on the staff intranet so people can see what I've said as well, because I think it's important that people hear what we're trying to achieve here. So, okay. You happy for me to kick off? Yes. And look, if you've got questions as I go, feel free to put your hands up. And I have warned members of the exec team that I may come to them at any point. So do. Right, so welcome to the Trust. So as I said, some of you have been here a couple of days already, and many of you have been here a number of times before. We run two main hospitals. We've got Queen's Hospital here in Romford, and we've got King George Hospital in Ilford as well, and Barking Community Hospital, where we're increasingly trying to run more cold services, more diagnostic services to support people across our patch to get access to the care that we need. And we're in an interesting part of London. Now, North East London as a whole is home to 2 million people, and our part of North East London, the three boroughs we're in, is home to 750,000 people. But that's growing all the time. And there's a statistic that Nick likes to quote about, I think, £4 billion worth of investment coming into this part of North East London. We're expecting significant six-figure increases in the population in the years to come. I think the leader of Barking Council told me that they've got more cranes in their borough, they reckon, than in any other part of London. And actually, if you're on the top of the car park at night, you can see the red lights stringing there. So there's huge development coming into the place that is really changing the makeup of the population around here. And that does, though, bring with it opportunity, but it also brings with it some issues. And we've got significant challenges around deprivation, around health inequalities, lack of access to primary care, and underinvestment in community and primary care. And what's really stark when you look at North East London is when you look at some of the levels of investment, for example, in public health in our boroughs, compared to some of the investment that's happened in other parts of London. And also look at things like the place spend on primary care. So our three boroughs are here, Barking and Dagenham, Havering and Redbridges. It's weighted NHSE data using the population profile to produce genuine comparatives here. And parts of our borough are really low in terms of access to primary care. And those of you who've been on site and seen what's happening on the front doors of our two hospitals will know that actually our acute hospitals have become, for some people, the default point of access into primary care. And that's one of the reasons that the sites are under significant pressure. We also have some hugely stark inequalities in terms of investment in community care as well. This again using NHSE data that the integrated care boards provided to us. But you can see that our three boroughs really struggling for the spend for the population compared to places like Sydney and others, where actually we know they have better flow in their acute hospitals and stronger integrated care in their patches. There's also significantly more investment in those areas. And one of our hopes through the integrated care partnership in North East London is that over time we can start to address some of those inequalities and start to help us build stronger services for people here. Because that primary care and that community care, it affects what happens at the front door of the hospitals, it affects what happens at the back door of the hospitals, and those two things together are what creates that crowding and that poor patient experience right through some of our emergency pathways. So a bit about the Trust. Our annual income last year was around 830 million. That included a bit of COVID money. And we saw around 7,200 babies born, really big maternity unit. I think those numbers were up to 80,000 before the pandemic, so it's taken a bit of a hit, but it's starting to come back again now. And we've got around 8,000 permanent staff. We'll show you a bit more about the staff in a bit, but just to add, we've got more permanent staff working for the Trust now than at any point in its history. You know, we're still a way off from being where we need to be comparatively, but I'll tell you a bit more about that as we go through. And we have busy emergency departments. Some of the numbers are lower than they were pre-pandemic, but as we've seen right across London, those lower numbers aren't necessarily translating into any kind of recovery and performance. And there's some factors I'll talk about that might explain a bit more about that as we go through. And it's also worth saying that this part of London was hit very hard by COVID-19. We do have much more diversity within our population. We know that people from Black, Asian and minority ethnic populations were hit much harder by COVID. Many of them because of economic circumstances driven by racism and inequity of opportunity meant they had to keep exposing themselves to risks during the pandemic. And, you know, so while some people were able to work from home in an environment that protected them from exposure to infection, and if you're traveling around this part of North East London, the people that were out on the streets providing those vital services often were non-white, and actually that was exposing them to risk. And same with some of our staff coming in here as well. And so we saw a lot of deaths here. That, I think, has affected some of the staff who were working here, who were working on wards where they might have seen a couple of deaths over the course of the year, are suddenly coming into really high levels of mortality. And actually that has left a legacy in North East London, as it has across the NHS. But you can see here, you know, we've successfully treated close to 9,000 people for COVID, and those numbers are still ticking through with much more in that success column. But we did lose more than 2,000 patients, most of them during those early waves of the pandemic. And that has left its mark right through the hospital, as it has for all of us. But this part of North East London, many families who've been touched by that. And it saw that really dramatic increase in critical care capacity. It saw the hospital at one point, I think, almost running out of oxygen. We've now got a fantastic oxygen system, actually, as a legacy of that. So there's been some investment that followed that, great extra critical care capacity. But actually what is left is some legacy in terms of improvement in services. But psychologically, for a lot of the staff, this is going to live with them for the rest of their lives. And I think that sometimes influences the way that people carry out some of their tasks these days. And I wanted to give a bit of regulatory history as well for you. It's the first time I came to this trust was to give warning notices to the chief exec of BHRUT, who was Avril Dongworth at the time. So the first time I walked into the office, it's now mine, it was to give a warning notices because the waits in ED were too long. And it was to raise concerns about maternity safety here. And someone will remember that well, where the maternal death rate here was really off scale, actually. And the trust did some fantastic work to address that. I think we could probably say that the issues around ED waiting time are still in progress. But I think it's worth reflecting, though, that BHRUT was into special measures not long after registration, was the longest trust to remain in special measures from the point of registration, for 4 years there in London. You know, so that was a really significant period of regulatory oversight there. And then back into financial special measures, and now we're in soft board, focusing once again on the emergency department and on our money. So there's some really consistent themes here. And one thing that's interesting about some of this is the instability in the leadership that's followed as a result of that. So I met Avril, and I think she was about 5 or 6 chief execs back. I'll say a bit more about that in a minute in terms of onto the organisation, but that's to give you some context. So what we're trying to do now is to do some different things to get the trust into a better path. Because actually the trust's been told repeatedly, you need to improve things in your ED. You know, and we're saying it over and over again without really putting in some different kind of structural work is not the way that we want to change things around here. So a couple of bits of really important partnership working. We're working with BARTS, and we've got Shane with us today, who's the group chief exec for BARTS and BHRUT, and Jackie Smith, who's our shared chair. And I'm the deputy chief exec across the group, as well as the trust chief exec here. And the aim of that collaboration is to give us a much broader base of resources across North East London to try to improve the quality of care in our hospitals, do some really important work on workforce, and to make us more financially sustainable. And that's about embedding the BHRUT as an independent trust in a broader framework of support that's going to allow us to do some things differently. And that context has encouraged some of us to come here, and that encourages helping some of us to bring some more people here to help us with some of our most challenged areas. We're also, as you're aware, at the minute going through broader system change. We've got an acute provider collaborative, which is basically our 2 Trust plus the Homerton. And we've got an integrated care system that's just finding its feet now. We've lost the CCGs. So we've lost some structures that supported the trust footprint, and that's been replaced with place-based partnerships that are just starting to find their feet this winter. And overall, what we're seeing is that we're trying to put a broader framework of partnership around us to support us to do better here. And that gives us a different context to start to be hopeful about what we can achieve. The next thing then also is about leadership and direction. So in my last trust, Oxley's, which is a really good, well-run organisation, I was the 3rd chief exec in 20 years. I'm the 4th in 4 years here. And we've heard various numbers talked around about how it's a bit like Doctor Who, I think, here really in terms of regeneration, but there's been very, very rapid turnover of chief execs. And what that does is it creates instability. The exec team has been made up of interims over periods of time, really rapid turnover. I think Catherine is our most established member of the exec team, and has seen multiple chief execs in her time here and multiple other colleagues. And what that's meant is colleagues who've been working in the divisions have seen an ever-changing catalogue of people coming in with different ideas, different priorities, some saying very openly they're only here for a short period of time, and that's created instability. It's created a lack of strategy over time. And it's created an environment in which the divisions, I think, have sensibly tried to look after themselves and their people, but not necessarily done so in a way that's really brought the trust together in the way that it needs to do. And I think that stability from the execs is a really important part of what we're trying to do. And we now have a stable executive team in place. Janine is joining us as Chief People Officer, first day tomorrow. So feel free to interview her. I think she finds her feet here. But what we're really trying to do is to build a group of people here who know what we're wanting to do, working with our non-exec directors, working with the leadership teams in our divisions to build a stronger trust with a clear view of where we want to go. And we want real visible leadership as well, promoting BHRUT as a place to work. And a lot of us spend a lot of our time on the floor, talking to the staff that work here, engaging with them about what their challenges are and what the opportunities are. And it's a really important part for me of building a trust that can address its quality concerns and really succeed in the way we want it to. We're also changing the structure, and that affects some people in this room. They'll be sitting there thinking, yeah, I wish you'd get that resolved, because actually, as all of us know, the process of changing structures creates uncertainty and it creates anxiety. But we've had a divisional structure that's been cross-site. And as I think some of you have found, that means that, for example, King George often doesn't get the same level of attention as Queen's does. It meant that when I came in and I said, who's responsible for flow at King George, the answer was, well, about 7 people, and they all report in a cross-site structure. It's not really anyone's job. And we've had too many examples of where, because of the way things have been designed, no one's really taking responsibility for certain things. So we're going through a process of changing our structure, where we'll move to 5 clinical groups, and they'll be cross-site, working on clinical strategy, on developing the future direction of the organisation, bringing in the workforce we need, and really establishing ourselves as a clinical force in the context of the collaboration in the APC. And then we've got site-based triumvirates, some of whom are in the room today, where we're really looking to give them ownership of the day-to-day flow of the sites and improve that patient experience. Our biggest problem is that flow right through the emergency pathway. It's unacceptably poor for the patients, and it's difficult for the staff who work here. And I want those site triumvirates to really take ownership of that day-to-day ops, supported by clinical groups who are looking more at the long term and establishing ourselves as a good clinical force there. Just working our way through that, and in March we'll have a managing director starting at King George. I did a similar job myself at the Princess Royal for King's, and it does work having someone on site who walks the corridors every day, speaks to the people there. It helps you build a sense of a hospital that's going places where King George is, but it needs that local leadership in addition to the cross-site work that we're pushing through. So, as I say, you'll speak to people over the next 2 days who are being moved around in this process, and that will create uncertainty. We recognise that. We've tried to be as open as we can about the process, not been without its wrinkles, and people will tell you about that. I want you to get a real sense of what it's like to work here just now, and that'll be part of what you hear. And also, we haven't got a strategy. So I'm not going to knock one up quickly and pretend we have. We don't have one. We haven't had one for a period of time. That's come about because of the instability. What we do have is an annual plan. That's a board-approved annual plan that sets out goals for us and tells us about where we're going. And our next step is working with our partners in the collaboration to really understand what a strategy for our trust looks like in the context of the collaboration and the acute provider collaborative. That plan that says this is our purpose, this is our objectives, and this is how we're going to go about doing it. So you won't find a strategy in the trust for the organisation as a whole, but you'll find the elements that do tell you we think we know what we're doing and we think we know what we're working towards as we build on. So a couple of the challenges we're dealing with. Culture. This is what everyone wants to talk about BHRUT, the culture, what's the place like? And actually we get very poor staff survey results, consistently difficult staff survey results, where too many people report an experience of bullying in the workplace and experiencing discrimination. And actually where people also report concerns about the quality of care that we deliver. And that point about talking about whether they're happy to recommend the care that we provide. Interestingly, some of the groups that we did, focus groups after that, one of the reasons for that has been the queues that people see outside. And actually, when people walk in and out of our hospitals in the morning, psychologically, they see a hospital where people queue for too long to access care. And we found through some of those focus groups that staff said, well, actually, my own service is fine. I wouldn't recommend it to a friend or relative because I know if they come there because they need urgent treatment and care, they're going to have a poor experience. So that's an important part of how we try to address some of this. But we do have this, and we have junior doctors who report poor experience of training. Me and Mamt and others doing a lot of work with Health Education England to understand that and get into the skin of that. And I know you'll speak to the junior doctors. And what you're going to hear is there's a lot to fix, but I hope you hear that we're doing the right things to give them confidence that we'll try to put it right. We've seen some improvements in our res and our disability equality data as well. We've got more 8As and 8Bs who aren't white now. We're also changing representation in some of our more senior roles, but there is, as with the whole NHS, that sense of a ceiling. of aspiration where people reach certain levels and start to struggle to move above that. And that's an important part of our strategy for a trust, especially in such a diverse part of London. We've got that underrepresentation. And we know that BAME staff with disabilities have a poor experience. And interestingly, I've had more people talk to me about sexism here than in any other job I've had in the NHS, and particularly female doctors, that they've talked about their experiences of sexism has been a really difficult part of working here and something they really want us to address. So we are trying to take quite a hard line on that now. We're trying to be really clear about the steps we need to take to address that, both in how we manage formal grievances, but also improving the way that we informally manage concerns when they're raised. Because some people don't realise the impacts of the way that they treat their teams and the people around them. And actually, we'd rather address this by improving the general standard of our management and leadership, because that's the way that we get this right for more people within the organisation. But lots of this, these are some really long-standing issues. And because the chief execs change so rapidly, you know, if you want to manage out someone in an organisation in the NHS, it can take you 2 years. And, you know, I'm just waiting to be called for an employment tribunal for someone we made redundant from Oxley's in 2019, and it's been listed for next year. You know, so that's a 4-year process to remove one member of staff. And so that kind of formal stuff takes ages. And actually, if the chief exec changes every 6 to 12 months and the exec changes, it allows some people to just keep behind the radar, bumping along, doing the wrong thing, because they know there's not going to be anyone there for long enough to really get under the skin of what we need to do to fix this. So this is going to be a long job, but there's some long-standing cultural issues we're cracking on with. So we need to deliver change. We've got a new chief people officer joining. That's a board level post. Janine's head of EDI at NHS England. And she's done some really good work in public and private sector on EDI. It's data-driven improvement work about improving organisational culture. So we're putting in quite a heavy load on her shoulder, but she'll be part of a really supportive executive and leadership team. And it's facilitated by a couple of things. I don't know if you've seen Workplace. It's our kind of staff internal comms system as well. It's very accessible, really great way to share information with people and connect with people across the organisation. Some great staff networks. We've just gone out to recruit for a shadow executive team, which is something I had in a previous trust. So we'll have a group of 12 staff who get full access to the papers that go to the exec team, who discuss them and then meet me to discuss them, and I'll contribute their views into the exec team. And what I found in Oxley's was that actually, if you ask a group of 12 staff who are actually often more junior, more frontline, more involved in clinical care, they often have quite different perspectives on some of the stuff that comes to an exec team. You know, it was interesting talking to staff who worked in mental health wards at Oxley's about the use of restraint compared to people who were sitting in a board context saying we should ban the use of restraint. And then you have a member of staff who comes in and says, well, what do we do about the person who just turned around and punched me in the face last week on the ward? And that wasn't a voice that we had because we didn't have those people contributing to that. So all this for me is bringing different voices around the table and creating an open culture. And I hope you found our staff have been open with you. We've got an independent freedom to speak up guardian. I know whenever reporting data goes up in the NHS, we say it's a good thing, and it goes down, we say it's a good thing. This is a good thing. You know, more people are using the freedom to speak up guardian. They're using that channel. In addition to what we need to do to strengthen line management, these are good ways for people to raise their concerns with this. Patient experience, our CQC and patient survey from last November, the results were pretty awful. And Catherine and her team have been doing some really hard work to understand why that's happened. We've been running our own audits that you'll hear more about over the next 2 days to try to understand what we can do to improve that. But there's a long way to go. Something we're also introducing are patient panels, which we're starting in paediatrics, and I want to do them in frailty as well, where we're inviting a group of recent inpatients and their families to come in and meet the leadership team in the service and talk to them about their experience of being cared for in the hospital, say what was good, say what didn't work, and then we're going to invite them to come back a few months later, and then we're going to ask the service team to present on what they've changed as a result of that patient feedback. I think we spend a lot of time dealing very formally with patient concerns. And actually, so much of it, we need to spend more time listening to people's less formal experiences of being cared for here. You know, the clinical care was great, but I couldn't get a good night's sleep. You know, we know in paediatrics, the Wi-Fi is not good enough for some of our younger patients who want to use their devices while they're inpatients. You know, there's all these factors that will come through in that, I hope will help us start to become a much more responsive trust that really listens to what people say about our care, not just through complaints. You know, because the complaints gives you a very skewed view actually of how you respond to people's concerns. And we've got some fantastic initiatives like our Daisy volunteers who won winners at this year's Penna Awards for the work they do with dying patients. We've got some really good pockets in this area, but until we see those numbers start to change for patient experience, we won't be confident that we're doing the right thing here. UEC, urgent emergency care. Queen's in particular has been notorious for its 4-hour performance, worst in the country for type 1. Someone on HSJ said us getting off the bottom of the national chart will be like the Ravens leaving the Tower of London. So I'm determined to make that happen, and I will be ringing them up when that happens and asking them to cover it, you know. So, and we have been focusing on Queen's, and I think what you've rightly fed back to us this week is we need a bit more focus on King George now, actually. But what we have seen through Queen's, through Operation Snowball, where we're pushing some of the risk throughout the hospital to balance risk within the organisation, where we're starting to try to put some of our staff into PELP, where we've brought GPs into our leadership team. We've seen a 9% improvement in type 1 so far this year. Although, you know, even if you pull out the winter dip, what we're starting to see is sustainable changes there. And we've got some more big changes happening in the next couple of weeks. We're going to have a surgical assessment unit to take all those surgical DTAs out of the SDEC. That's going to give us a good, better flow in the beds area there and in the non-bedded area. We're going to have big SDEC, which is our technical name for expanding into that big Majors B area that used to be a really unpleasant and depressing part of the hospital, actually, when I got here. Do you remember when Jackie and I went, I was furious about the state of that corridor. So all these poor people sat there in a really inappropriate environment. Now that we're holding the line more clearly about not allowing type 3 patients to leak through into majors, that's given us more space there to allow us to open that into a much larger SDEC, which ultimately will help us in the urgent treatment centre and primary care. And we're also looking at a separate children's entrance. The atrium in the evening is not pleasant. You know, it's busy, it's noisy, it's not a good place for kids to be. And what we're looking at doing is creating a separate entrance into urgent care and treatment for children and their families to come into as well, which I think will help everyone in terms of the general feel. I'd like to get that queue out the atrium entirely. It's not right having it in that place, but there's a few longer term bits of work we need to do to really address that. And the other thing I want to raise is mental health in ED. We've got really dreadful experiences. And I think we had a child who came back in last night, 4th admission in 11 or 12 days, who's now ended up going to a tier 4 bed, but she's spent, I think, close to 200 hours in our ED over the course of the last 12 days or so. Local authority unable to do anything to help us get her out of there. We have mental health patients regularly waiting in excess of 36 hours. Some really significant problems, both about getting assessment done on time, but also about getting people moved into appropriate inpatient services. Got a couple of plans for winter. They're more about us providing a calmer environment on site for people waiting for inpatient beds. But it's really difficult. And I think we're in a context where multiple of our wards this morning will have an extra patient on them to allow us to try to manage flow in the ED and get people off ambulances. I spoke to Sam yesterday because at one point we had 10 mental health patients in ED here, and we had people in their 80s waiting in the corridor on trolleys for us to unload, while we had 30-year-olds in ED cubicles waiting for mental health assessment. And people with mental health problems have got every right to come to ED in a crisis, but they need to be seen properly and promptly by a liaison, and they need to be taken to a much better place. And this is really a problem for me. And I have to say the response we're getting from the ICB in North East London has been a bit lukewarm so far on this. It's on their radar, but it's not been good enough. And I know, Shane, that the problem at Barts is similar. Really difficult problem. I was in a mental health trust before, and I have to say we were struggling with this as well. Not easy, but I think there's something about the sharing of risk and capacity that we haven't got right. But we know, we've heard what you've said about King George as well, and then we recognise actually that the Queen's focus, you know, we need to start to shift some of that focus across to King George now as well. The other things, maternity rated requires improvement 2021. We've had some support for National Maternity Safety Support Programme. We've been doing a lot with maternity voices. We had an Ockenden inspection a couple of weeks back from NHS, and actually they found a lot to be positive out there. And we put a new team into maternity. We've been working extremely hard to get that service into a better place. And I think if you came and looked to get at it again now, you'd find a better service, you'd find a better led service, and you'd find a more optimistic service. I think our ratio of midwives to mothers is 1 to 24 at the minute. That will be put under pressure if the birth rate starts to go up again. But we're in a good place at the minute. I think in terms of the midwives there are caring for fewer mothers than they've ever been. It might not be what they tell you if you ask them. You know, it might not be their experience that they want more staff. But we know we've got the data to prove actually that we've invested a lot in that service and will continue to do so. So there's been a lot of change in leadership there, and I think they're in a better place than you'd have found us in previous years. And reducing waiting lists, and we've got Amlesh in the surgical team here, by Joyce and Liam and others. There's been some real successes, and of course waiting lists are actually right across the trust, including in specialist medicine and other areas. But we've really tackled our 104-week waits. Our 78-week waits are really coming down. Largest reduction of any trust in London, although some trusts didn't have any, did they? You know, but we've had to make some real inroads into that. And we're part of the NEL Cancer Alliance, and you know, we're very good for the faster diagnosis standard. Got some other challenges on our cancer pathway. and that we're trying to work through with our partners in North East London. But King George is going from strength to strength surgically. The protected surgical hub there has been a really big factor and has eaten into those waiting lists. We've got NHSE money for 2 new theatres there. There's an independent sector treatment centre there that runs some pretty inefficient, lovely theatres attached to our building. We'd love to have that contract. We could do more with it. We could do better with it. But the ICB and its predecessors have often made decisions to disadvantage this trust. I think because they didn't have confidence in the leadership of it. We're hoping to change their perspective and get the services we need to really do what we know we can do around the backlog. And really importantly, a beautiful new community diagnostic centre coming at Barking Community Hospital. That'll help us keep more people away from here and give people that experience of care closer to home. And look, this is what's happening with our PTL at the minute. So the blue line there, it's dropping. The orange line is the 52-week waiters. And actually, because we're treating the longest waiters, that's not coming down quite as quickly yet, but it'll start to. But you can look at what's happened in October here in our specialties. You can see those numbers dropping as we really eat our way into those backlogs. And that's not just about operating, it's about outpatients as well. It's about really managing that whole pathway and understanding how many people there are waiting for our care. We know we've got more economically inactive 50-year-olds in the country now than we've ever had. Lots of them are on our waiting lists. And when we had a look last winter, we knew that 3 out of 5 admissions for emergency surgery were people that we found to be already on our waiting lists. So not operating on people's affecting the emergency care pathway in primary care, as well as it is what we do in the trust. But this is working well. It's driven by what the surgical teams are doing around super clinics, where they do these really focused bursts of activity, which I hope you'll hear more about in the course of the next couple of days. But what these do is they really allow the teams to look at the process and the flow that underpins effective practice. We look at things, I know we talk about things like early starts, etc. in theatres. Actually, people who don't attend is the biggest waste of money in the NHS in terms of surgery. And we found interventions like the surgeons or their teams phoning up patients, but really simple thing. People turn up when someone's rung you and said, I'm looking forward to operating on you tomorrow. Those folks turn up. We've got a team working out of outpatients in King George at the minute, ringing people the week before their appointment and speaking to them, say, are you coming in next week? That's reduced from 15% to 9%, or do not attend for outpatients there. And it's all these process things that allow the surgical teams to do the fantastic stuff they do when they get the patient in theatre. And there's some really fantastic work going on right across all of our specialties there. So on to money. We'll spend about £810 million this year. Most of that on staff, quite rightly, but also quite a chunk of that staff money will go on bank and agency. And we've really been working hard to get those agency costs down. Some cases where we've been paying people much more money than our permanent staff to do the same job, often to not as good a quality. And it's a really important fairness point for me that we reduce that money that we're wasting on high cost agency staff. We're on track, we think, to deliver a deficit position of around £20 million with an underlying deficit of around £70 million. £20 million is, that reflects some really significant work on high cost bank and agency. There's going to be challenges to get there because we know we've got industrial action coming, and we know we've got some specialties where people are going to start withholding labour and doing extra shifts over the winter to try to push for higher rates. So there's challenges in there, but we're starting to see that move in the right direction and really invest in permanent staff. And the other big exciting thing about the trust is big investment in capital. There's building happening on a number of our sites. We're actually quite lucky with the fabric of our buildings. This, as far as modern PFI hospital goes, is one of the better ones I've been in. King George, as far as what I call classic hospital goes, is a good one. It hasn't got bits falling off it. It's lovely and bright. It's well laid out, actually. And there's real opportunities for us to capitalise on what we do in these 2 sites and at Barking Community Hospital. And really importantly, that kind of Indiana Jones warehouse there is our, we're the last acute trust in London without an electronic patient record. That creates all kinds of safety and risk problems. It means when we get new staff coming into here, our message is step back to the 80s and join us on paper. It's not modern practice. And all these things we know about electronic prescribing, about electronic records, all these things create risk. And it's great, actually, that working with BARTS, we're looking at rolling out an EPR for this trust over the course of the next few years. And we've got NHSE in North East London to support us for this financially. But for me, this is probably going to be, in infrastructure terms, the biggest thing that happens in the trust in the next 5 years, is giving our staff access to an effective, safe, joined up electronic patient record that will improve quality and safety, improve staff and patient experience. And whenever I meet a family to talk about a complaint and I have to pull out a couple of phone books worth of handwritten notes, say somewhere in here is the story of what's happened to your relative. This isn't what we should be doing. And this is another example of decision making has meant this trust has not had the assets it's needed to do its job properly. But we're finally starting to get some real traction around that. And on the money as well, we've been doing some really good work with BHRUT about drivers of the deficit across North East London. Within our trust, we think there's around £100 million worth of opportunity. I think it's about £120 million at BHRUT. But what we're doing is we're working together to learn from each other about how we take this cost out. So of that 100 million here, we think about 50 million is what we're calling operational. Some of that's around productivity, some of it's around high cost staffing and the way that we drive those costs down. The rest of it is more strategic. So CNST, we pay out a lot on that. We need to get that into the right place. And we also need to look at people who are in our beds who could be cared for elsewhere. It wouldn't just be cheaper for us, it would be much better for the patients. The 90 or so people who are always in our beds who should be in a social care setting or in their own homes with care. And that's a really important thing for the system, for us, and an opportunity for the trust. And of course, workforce is at the heart of these programs. And I love this graph. That black line. So whenever you hear from our staff, which they will tell you, it's in the NHS, and you say to people, "Have you got enough staff?" You will rarely find people say, "Yes, we do." But actually, what we know is that 2 years ago, we had 6,592 permanent staff here. We've now got 7,300. And that's been increasing consistently over the course of the last 2 years. We've got more nurses here. We've used the Safer Nursing Care tool to understand where we need those nurses and in what numbers. We use the nursing audit of the patients on their ward to decide where we put those resources now. We've got 150 more doctors than we had at the start of the pandemic. We've brought in ward clerks and other supportive staff. The majority of that is clinical load to try to bolster the quality of care that we offer here. And we're still not in some areas on a par with peers. So some of this is about correcting, again, historic underdevelopment and underinvestment in our staff. But we have more permanent staff here, and the bank use is the blue and the red is the agency. And really what we've been trying to do is cool down that really high cost, wasteful agency that creates unfairness and drive up permanent staff. And actually, we've had some really significant numbers of permanent joiners recently. And the workforce element of everything we do is at the heart of us building a stronger trust here. And actually, when you see what we think are our risks, of course, it's workforce, it's money, it's performance. You'll have risk conversations with us over the next few days. I imagine most of what you hear will be reflected in those kinds of dynamics here. But we're trying to become a trust as a strong board assurance framework that reflects the risks that we understand in services and that really starts to drive a learning culture here, especially with things like PSERF coming in to help us take a different approach to learning from incidents. And we've looked at Blackpool, Medway, trust with similar bed bases to us, and looked at our incident reporting. And as with the freedom to speak up, we're starting to see positive upward trends where people are prepared to say, this hasn't worked, this has gone wrong, what can we do about it? And there's a lot for us to do on that there, but I think we're starting to really build this good reporting culture that encompasses all those risks we've talked about. We've got some fantastic people working here. Really wonderful staff working here, really interesting stuff. Just before I came here, I just went and got a cost in. The assistant manager there told me that we're the third busiest in the country. She's had confirmed to her this week after Gatwick and Heathrow. I said, well, why do you work here? She said, I've been here 6 years. She said, I was an inpatient here for 4 months, 6 years ago. And she said, I had such good experience of the care here that I wanted to come and work here. And we've got all these fascinating, I know all hospitals have got amazing stories with them, but this place is riddled with them. And I think, we've got some fantastic rising stars amongst our nursing staff. We've done some brilliant work for career opportunities for young people, particularly those that have come through care, to find opportunities for employment, reinforcing that with things like our apprentice programme. We're about to become a training provider for apprenticeships to really start to pull more of those apprentices into the organisation. And some great other awards. We've got the Academy of Surgery, which the surgical team have done. It's been an outstanding piece of work to attract people to come here and develop across the world. That won People in Organisational Development Initiative of the Year. And we've got individuals like Ambalika Das in paediatrics, really pushing and promoting some of the things that really matter to our staff. And we've got more in the pipeline, performance recovery around our elective work. And Lash's at the back of the room, and we're going to have to build him his own wing if he gets Clinical Leader of the Year, I suspect, but he's been a brilliant champion for our elective recovery programme, actually. And whatever the outcome on the night, the work he's done within this trust, also regionally, has been really outstanding in terms of really promoting some of that good practice and leadership in surgery. And I think, nominated for that. And also Nursing Times as well, the preceptorship programme, our international recruitment, UK Employer of the Year for nursing staff. There's some real assets here. And this isn't the stuff you always hear in the stories about BHRUT. You know, people have a narrative about this trust that's been quite dominant. That makes it hard for us to attract and retain good people. And one of our jobs here as a leadership team, working with people like the people in this room, the people that run our divisions for us, the clinicians that work on our wards, those of us that are here to support them, is to start to change that narrative and show people that this is a place where we've got a plan, we've got the right people, and we want to make it happen. We've been doing a lot this year, of course, to look after those staff as well. Cost of living support, we had a school uniform marketplace earlier this year. Now, this is all about getting people's money into people's pockets in a way that we can't do just by giving them cash. You know, so we had a school uniform exchange, and we're now going to be offering free period products to women at the trust through to the end of the financial year as well. These are all ways in which we can support our workforce and help them through what we know are difficult times. Financial wellbeing, we're a food bank referrer for people who really are in need, and I think it's shocking and shameful that we're in a position where fully employed NHS staff might need to use a food bank, but that's where we are, so we're doing the things we need to. I think that's a really good set of wellbeing initiatives that reflect the place we're in and the people we care for and the people we employ. We also had a thank you weekend this year. More than 3,500 staff took part. Me and the keyboards there, and on guitars, you know. But we had all kinds of things. We had a lunch, a breakfast, we had a family fun day on the Saturday, so people could bring their kids out and have a free day at the fair for their kids and families, which really means something to some people around here. Can't afford to do that otherwise. And I think we knocked that out. We figured out it was about £20 a head, Catherine. I can't remember the numbers, but it was a cost-effective way of getting things to people who need it and actually showing that we value them. And the chance to get all those people together in a room after everything we've been through in the last few years, you know, that was one of the best nights I've had, actually. Just the feeling that was coming up from people in the room there. And those lunches that we were having, just the smiles on people's faces, that sense of being in a place that cares, really, really important. So what does the future hold? Stable leadership here, embedded within a collaboration and a partnership that's going to give us greater strategy. We're putting the right structure in place, and then we'll build a strategy with our partners that reflects where we want to go. And that important element of working in partnership to get the best for patients and staff. A really good focus on emergency for both sites, whole hospital, to make sure that people are not experiencing the kind of unacceptable waits that happen at the front door, and to try to get, you know, I don't want our ED staff to come in the day after the previous shift and see the same people in the department. You know, we've got to change that, and that is a front to back door culture change, and that's a change in the organisations that support us outside the hospital who don't feel this same pressure and who need to feel more of this pressure and more responsibility to help us with this while we sort out what's within our gift. And we really need to pick up some of that fantastic initiative we've seen within surgery and elsewhere to get those waiting lists down. We know too many people are waiting for the care they need, whether it's diagnostics, outpatients, treatment, etc. We want to make it a better place to be cared for and a better place to work. And we'll have metrics that show whether we're succeeding there. And we want to attract new people into the trust and keep the great people we've already have. As much as the NHS has got a recruitment problem, it's got a retention problem as well. And if we can really start to encourage people to stay here and invest in this place over time, we've got a bright future. And we've got some big capital investments coming our way to help make this a better place to work and be cared for. And those last two bullets, I want this to be a great place to work and a great place to get the care you need. You know, as simple as that. That's what this should be for the people that come here and rely on us. And I want to build that through the efforts of committed, well-supported staff who are well led by people that know what they're doing and are prepared to stay the course. And that, for me, is how we get out the cycle this place has been in. That cycle of problems that begat problems and that create change and uncertainty in the leadership here. And then, I mean, I've been here 14 months now. I'm really enjoying myself. Not all the time, but most of the time, I'm really enjoying myself here. And I'm enjoying it because of the people I get to work with and because of the change I can see that we're making. And actually, because I'm not naive about the challenge here, but I am optimistic that by doing the right things in the right way, taking our time about it and getting it right, I think this trust has got a really bright future. And I think all those fantastic elements of good care that we've got, actually, they will shine all the brighter once we can take some of these really significant problems off the child. So there we go. There's the biggest cost outside airports in the UK and Pallet as well. But it's a great place to be, and I'm really glad you're here. And I hope you have a really interesting experience over the next 2 days. Thank you.